A 68-year-old female patient arrives in her office with her husband. She's new to the area. She says everything is okay. I just want to establish myself. But everything is not okay. How do you talk with her? How do you get her confidence? How do you explain things? And how do you set up the treatment plan so it's in the correct sequence so that she can accept it? That's what we'll talk about today in practical treatment planning. So let's look at the retracted view, and you see the upper right central incisor. It has a crown on it. You'd think that aesthetically that would bother her. Take a look at the red gingival margin. No, that doesn't bother her at all. Nothing really bothers her. At the same time, there's pathology here, and the pathology is the biggest problem. Let's take a look at this FMX first, and we'll go through this sequentially. Stay with me because I'm going to give you a method of going through treatment successfully so the patient can have options and so that she can express her options and she can determine how she wants to develop the treatment plan, always keeping in mind that infections need to be treated first. So let's look at the full mouth series. I'll go through this briefly, and we'll go through it one by one. You'll notice there's very little problem as we come across here. But take a look at tooth number 8. Tooth number 8 has, you can see this dark radiolucency right here. That's an infection. Apical lucencies cannot be watched. You know, when I was a little kid, we were watching them. We don't watch them anymore. Apical lucencies means apical infection, and certainly this contributes to a medical problem or potentially contributes to a medical problem. We have to inform the patient. It's still the patient's choice as to whether it's going to be treated or not, but this becomes not just a dental problem, it's a medical problem as well. As we go through here, you'll notice a peg lateral. None of that seemed to bother her. You might see a little bit of an open margin here. Small apical lucency on tooth number 13, but that will not be bothersome as you see, or won't be a pathological problem, at least in my opinion, based on what we see on the CT scan. We'll go over that in a minute. But there's an open margin, but it's fine clinically. It's okay. If we go down to the bottom, everything is looking good until we get to this. Okay, and now we have endodontic treatment done by Silver Points, done very many years ago. It looks okay so far. You might see a little bit of a problem on the distal of number 29. But now take a look at this shadow. And you see the shadow right here, and that shadow in here is indicative of caries. And if we put an Explorer under the facial, I can feel the caries, and it's deep. We'll look at the bite wing. You'll see less of an indication there, and that's why it's important still to take a full mouth series. I know some of us are relying now on bite wings and CT scans. A full mouth series will still give us more information, and certainly with the Nomad, it makes it very easy to take a full mouth series, at least on many patients, if they're not gaggers. As we look at the CT scan, I'm going to scroll through this. Most areas are going to be fine, so I'll go rather quickly on this, and let's go right here to tooth number 8. Now you see this radiolucency on tooth number 8. If you want to make it bigger, we'll make it bigger. Take a look at that. And that radiolucency essentially is loss of the facial bone here, and you've got a chronic infection draining from the apex, from the area where presumably the endodontics did not get all the way up. You can see actually a loss of the contour and external resorption from the apex, but this is a chronic infection. This chronic infection cannot be ignored. It needs to be treated. Let's continue through the CT scan. And everything is looking good. We'll go to this endodontic area that we saw. But notice in the endodontic area in tooth number 13, the bone is intact there. So I'm not worried about that one at all. Go through number 14, number 15. Now let's go down through the lower arch. We'll go all the way through here. And you'll notice everything is looking good here. CT scan, important, isn't it? And I'm going to show you a method here. By the way, here's that area on tooth number 30, okay? So number 30, there's caries here, but there's no apical lucency here, and therefore the pathology is not there, and that's why I'm going to give the patient some options, and we'll talk about how we sequence that and how we discuss that with the patient in a moment. Now, for those of you thinking about getting a CT scan, let me show you this view. And if you take a look at this view, I can tell the patient, hey, you have got a hole right there. That's what that's doing. And this will register far better with the patient than if we ever show the patient that radiographic apical lucency there. Now she can see there's a hole in the bone, and there's a hole in the bone due to an infection that's draining from the end of that root. Now I want to dwell right here on the distal tooth number 3. There is a periodontal pocket there. Let me show you the pocket depths for a moment. And notice there's a 6 millimeter pocket in that area, a 4 millimeter pocket here, but that 6 millimeter pocket is bleeding profusely. Now notice the overhang that's here as well, and notice the bone loss that's here as well. And so we have a restorative problem that is creating a periodontal problem, again, something that can't be ignored. If we look at the lower arch in this bite wing, you'll notice, okay, this is the area where there's severe caries. You can get an idea of the caries and how far that goes. It goes nearly to the furcation, at least on this two-dimensional radiograph, but no furcation, no furcal bone damage yet. But take a look at tooth number 29. That restoration extends quite a bit gingivally as well, and we see a little bit of a defect here. Certainly that's something that we're going to address, so that when we address tooth number 30, we should address number 29 at the same time. An occlusal photograph often tells the story to the patient. And I know many of you are doing that, but take a look. We've got this amalgam here. We already know that there's a periodontal defect and possibly even caries at the apex of that distal box on tooth number 3. But then the question is, do we just treat number 3, or do we treat number 4 and number 5? Number 4, notice how thin the enamel walls are here. And number 5 is better. It has a DO, and the DO extends a little bit over to the mesial in that area. But this is a place where I can give the patient some options, and we'll talk about those options in a moment. As a matter of fact, let's talk about those options now. So in an area like this, we may very well choose to remove the amalgam, do a buildup, and do a temporary crown in that area. That would be appropriate treatment, and that's what we need to do. But I can also talk to the patient about tooth number 4 and say, while we're in the area, it may be a good idea to do this one as well, because there's a very weak enamel wall here, a weak enamel wall here. This area is prone to fracture. Now, you don't have to do that now, but I'd suggest that given how weak that is, given the fact that this is prone to fracture, I think you're going to need a crown there anyway. It may be a good idea to crown all 3 of those teeth, but I will leave that up to you. Very often the patient will then choose whether she wants to do 1 tooth or 3 teeth, or maybe even 2 teeth. She can make that decision on her own. We can give her pricing on it, and she can decide what to do, knowing that there's going to be a risk on tooth number 4, but not requiring to do number 4 because there's no pathology there, but requiring or saying you need tooth number 3 for health reasons. You've got a periodontal pocket and there's a bleeding there, so we need to treat this. How will we treat that? We'll remove the amalgam, we'll put a buildup in a temporary crown, and then we'll do crown lengthening on that tooth in order to be able to eliminate the periodontal pocket. And place that distal area where the caries or the restoration extends deeply on the distal, make that supragingival so that we can restore the tooth correctly and place our margins in a supragingival position, or at least at the gingiva, rather than burying them below the gum line. So what's our priority? It's this priority first. We want to refer to the endodontist. We want the endodontist to evaluate that and determine whether he or she might be able to do an apicoectomy on that tooth and seal off that area appropriately. That's number 1. Number 2, remember we're treating pathology first, infections first. So the next thing is a periodontal infection. It's not a periodontal infection that's due to chronic periodontitis. The chronic periodontitis is being influenced by the depth of the restoration, which was influenced by the depth of the caries on tooth number 3. So the next part of the sequence is to address number 3, remove the amalgam, place a buildup and a temporary crown on tooth number 3. If the patient is going to get crown lengthening, we like the temporary restorations to be on tooth number 4 and 5 as well. The idea is that we want to be able to remove the temporary restorations so that we have access to the interproximal bone and adjust the osseous surgery without having the crown in the way. So if the patient is choosing to get all 3 crowns done at one time, we want buildups and temporaries on teeth numbers 3, 4, and 5, and then that would followed by crown lengthening on number 3. Maybe it extends a little bit onto number 4. Doubt that it will be, but at least we can remove the temporary crowns, so we have access to the interproximal bone. Makes it much easier for us to suture the flap, much easier to address the interproximal bone if we need to. We then let that area heal in for 3 months, and then we'll Probe it, make sure that everything is okay, there's no bleeding anymore, the patient can take care of it, and then we'll put crowns on teeth numbers 3, 4, and 5. The next area of priority is tooth number 30. And notice that's not a pathology priority. So what am I telling the patient? You have decay. There's no way that we can restore this correctly. As soon as we remove the crown, all we'll find is jelly underneath that crown. There might be a little bit of tooth structure that's holding onto the crown, but eventually that crown is going to break off. It's up to you. If you want to wait till the crown breaks off, that's fine. As long as you have no pathology, we'll be doing a radiograph at least once a year to make sure that we don't get into trouble. But understand that this tooth is going to be removed. When the tooth is removed, then we'll replace it with a dental implant, and this is the way we design a dental implant. Notice we place the dental implant in our dental implant design software so the patient can see the dental implant. At the same time, given the fact that the restoration is so deep on the distal tooth number 29, we want to treat 29 and 30 at the same time. After all, the extent of this composite restoration almost impinges upon the attachment apparatus. We'll be extracting tooth number 30. It's very easy for us to create sufficient biological width on the distal number 29 at the same time as we extract number 30 and we put the implant in number 30. And then the final restoration will be a custom abutment on tooth number 30 and a new buildup and crown on tooth number 29, and we're done. Let's talk philosophy here. Understand that the patient could be required, could go to an office and say, you need to have crowns on numbers 3, 4, and 5. Part of the reason patients choose independent practices and private practices is because they want to get options. They want to be able to have a dentist they can establish a relationship with. This patient will very likely get the crowns done on numbers 3, 4, and 5. But it's not up to me to force her to get the crowns on teeth numbers 3, 4, and 5. Yes, 3 has pathology. It has the periodontal pocket, it has the overhang, it has the restoration that goes deeply below the gum line. If we treat pathology first and always look at it from pathology first and emphasize the patient pathology first, then they understand at least what our philosophy is. And so we talk about pathology and infections and what we have to do first. Okay, so what we have to do is tooth number 3. Now, what you may want to do because of the weakness on numbers 4 and 5 is a different subject, but it may be easier for the patient. The patient might say, all right, that makes sense. I understand why it's better for me to do numbers 4 and 5 now. We can talk about the fact that we can establish the occlusion better, that the crowns will then fit against each other better, the contact areas are easier and better designed if we're able to do all the crowns at one time. We can say that. But we can talk about those as being advantages, but not necessarily force the patient into doing the procedure. By giving the patient the advantages of doing the crowns on numbers 4 and 5 at the same time as we do number 3, then the patient has the power of choice. And that's what the patient wants, the power of choice. And then the patient can decide on whether that's okay for him or her. Maybe that patient can't afford the crowns on numbers 4 and 5 now. That's fine. They're establishing a relationship with you, just as they're establishing a relationship with us. You can tell them that you're going to be following them every few months. Understand this is prone to fracture, and sometimes that fracture may be a bad fracture, particularly with thin enamel walls. Sometimes we get the fracture in a subgingival area, and therefore the patient may need additional crown lengthening in order to be able to save the tooth. You can talk about what could occur, but that you'll give the patient the opportunity to make that choice. And that way the patient will choose number 3, or the patient will choose number 3 and 4, or numbers 3, 4, and 5 to be crowned all at one time. And that way the patient is establishing a relationship with you. You're giving the patient the pros and cons. You're even putting that in your consent form so the patient understands what choices he or she is making, and the patient can make the best choice for him or herself. Understand that our practice does very well, but we do very well not because we force the issue, you have to do it. It's because we've spent the time talking with the patient about the pros and cons, why things should be done, and the patient can make the decision for her or himself best. The second thing is we separate out the have-tos from the want-tos, okay? And so we'll be talking about cosmetics in a moment. The patient didn't even approach cosmetics. We'll talk about that in a moment. But understand the have-tos have to do with infection first, function and strength of restoration perhaps second, or strength of tooth second, before we get into the cosmetic work. If we talk in that language, the patient has a framework from which he or she can make a decision. Now, the patient could look at this from a cosmetic perspective. Do you like the way tooth number 8 looks and number 9? You see the contrast between the two? What about the peg laterals? What can we do there? Well, the patient did not address me for smile. And until the patient addresses me for smile, I'm not going to bring up the smile. I'm going to bring up pathology only. The patient may say, I'd like to improve my smile as well. It's at that point that we'll address it. So it's pathology first, pathology first, pathology first. Take the areas of pathology, treat the infections first. That's logical to the patient. And frankly, that's healthcare. And then you can move into cosmetic care later on if she chooses to do so at all. If you have any questions about this, just email me at lee@directorofdentistry.com. If you want to see more about sequential treatment planning, take a look at this video.